Good morning. Welcome to Online Anesthesia, postgraduate teaching program on Zoom platform, sponsored by Abdullah and hosted by A1 Logics, and simultaneously aired by Anaesthesia TV. We have two eminent professors in our pediatric anesthesia series session today. The first topic is induction, maintenance, and recovery of pediatric patients by Professor Dr. EKTA. That will be followed by the second topic, that is pediatric regional anesthesia by Professor Dr. ELSA VARGHESE. Today's session is coordinated by Dr. SIVAPRASATH sir. Over to you, sir.
Good morning, one and all. I'm really very happy to invite our first speaker, Professor Dr. EKTA ma'am, to speak on induction, maintenance, and recovery of pediatric patients. She is the HOD of Department of Anesthesia at Christian Medical College, Vellore. She is also a course coordinator at WFSA Pediatric Anesthesia Fellowship, and she's an associate editor, Pediatric Anesthesia Journal, and she's a subsection editor at JOACP, and she's a core committee member of Smile Train program in India, and she's conducting Hospitals course community BLS activity at Vellore. She's a BLS and ACLS instructor also. She's also executive member of Indian Association of Pediatric Anesthesia and a newsletter committee member at APA. She has over 40 plus national and international journal publications, and she is a speaker at many international conferences. We are very happy to have you here, ma'am. Over to you.
Thank you so much, Shanti. Is my presentation visible?
Yes, ma'am.
And am I audible all right?
Yes, ma'am, you're audible, ma'am.
Yes, ma'am, audible, ma'am.
Sure. Thank you so much. At the outset, I would like to thank the organizing team and Dr. Edward for allowing me to talk on this massive topic of pediatric induction, maintenance, and recovery. So I think my disclaimer is, I think keeping to time important. I think very difficult to cover each and everything. What probably we'll discuss in next 1 hour is going to be a normal healthy child, and it's very much postgraduate oriented discussion and talk. So to begin with, I think whenever we talk about anesthesia, we have preoperative phase, intraoperative phase, and postoperative phase. When you see a patient or when you assess a child or a patient, you always start off with the pre-op assessment, which includes history, examination, and investigations. And then you have this time frame where you develop a rapport with patients and then their relatives or their parents. And then you think about, plan of anesthesia for the next few hours. And then you think about post-op care. So that's exactly what I'm going to do in next 45 minutes or 50 minutes. I will begin with the concept of rapport development. I will skip on the assessment because that in itself take at least 10 to 15 minutes to just broadly cover it. So I think whenever we talk about induction and intubation, we have to think about if the patient is safe to induce, and also we need to think about if the child especially has got anxiety about the whole process of anesthesia. Are the parents anxious about the whole process of anesthesia? So I think if I make this statement saying that if somebody says that I will give a good anesthesia, keep the child hemodynamically stable, surgeon will say I'll do my best job and the surgery will be over, and doesn't matter even if we don't have a very good or smooth induction, but at the end everything will be all right. So is that the right statement to make, or is it okay, this approach is okay? So I think it's not the really right statement. The reason being there are a lot of implications of not so smooth induction, which can be short-term effects and also can be long-term effect. Short-term effects in terms of emergence delirium, they don't wake up very smooth. Intra-op, they required higher concentration of analgesic drugs, and also they seem to be more tachycardic throughout the procedure. Whereas the long-term effects is what we are really, really worried. They develop negative post-operative behavioral changes. Things like when they grow up as an adult, they develop sleep disturbances. They have got this behavioral changes, separation anxiety about a lot of things. And then they develop this, they can be new onset enuresis in children. So it is very important to think about a proper plan for induction, provided it's safe. Now, then you can have another school of thought where people will say, or the anesthetist will say, why should I bother? You know, when there's so much of impact about a bad induction, then might as well keep all my children sedated. And that's also a good plan. Again, let's see if we can strike a balance between the two, because remember, any medication you give, there is a side effect, and you need to be very careful in what you give, and you should give what is only needed. So let's say if we can see the predictors of not only anxiety, but the need of pre-medications. So in terms of anxiolysis, the major factors which play part are age, temperament, and the education status of the parents, if they are able to explain children what the child is coming for. So let's take one by one. So coming to age, if an infant who's less than 6 months, they barely have separation anxiety. And so we don't need really any pre-medication to allay that anxiety. So, and it's between 6 months to 9 months, they start to develop anxiety. But what happens if your caregiver or the anesthetist is gentle, then it's not so difficult to separate them from the parents without any anxiolysis or without any pre-medication. Now, in this age group 1 to 3 year, this is a very tricky age group where there is maximum amount of separation anxiety. The understanding of whole procedure is very minimal. So this age group children, they don't really accept even a gentle staff. Friendly environment may or may not affect them. And this is the age group which may need pre-medication. So you see how the patient is, and based on that you give pre-medication, especially in this age group. Coming to 4 to 7 years, this age group again is anxious, but their anxiety is mostly to do with the surgery, if their body part will get hurt, or if they die. These are the basic worries in them. So if you explain events carefully and in detail to these kids, usually it helps, and they become very cooperative if you talk to them and you build rapport with them. And it is a friendly environment in this age group, which is really, really beneficial. Coming to this 8 to 15 years age group, these are very strong. They look very strong, and they look very brave kids. Inside, there'll be a lot of anxieties and worries, and they're scared, but they don't want to show it. They want to behave like a lion, you know. And then thing is, friendly environment, talking to them, detailed explanation of procedure in itself is more than enough. And they usually don't need pre-medication unless there's, you know, they are out of those 2 standard deviations. So if I have to summarize the plan of pre-medication or anxiolysis, it has to be individualized plan. It has to be based on the child, and unnecessary and too less, both are not good. So I think see your child and plan for anxiolysis. Now, once you have decided that your child needs pre-medication, now question comes, which drug should I give? How much should I give? Which route I should use? And what exactly is my target? So your target basically is to create anxiolysis. Your target is not to have a sleeping child. So I think a lot of anesthetists I see, they try to put the child to sleep with medication, and they give very high doses. Problem is, these drugs act for some duration of longer duration of time. If you're giving long acting drug, and then you add intraoperatively some fentanyl, you add some other sedatives, and you add some more analgesics, and everything, all the action sums up. And in post-operative, either this child sleeps for a very long time, or they can have respiratory distress, etc. So choose your drug carefully. If I have to choose, I will choose a short-acting drug, something like midazolam, route which is non-invasive, like oral route, and then doses for midazolam is something like 0.5 to 0.7 milligram per kg. And you must know how long will it take, so that you can time your drug. Something like 20 to 30 minutes it takes for midazolam effect to come. So that's how you have to plan for your drug. Also, you should know what are the side effects. Let's say if I'm choosing midazolam, I know it is bitter in taste, so I need to add either sugar or I need to add some juice, happy juice, to kind of mask that bad taste. And I must tell the child that, you know, it's going to be sweet and don't worry. And you need to tell whatever you're doing, you need to tell your children. So when I mean by friendly atmosphere, you have to cater it to your child. You know, you can see in this video that this child is so playful. He's so excited about all these toys. And then finally, the one he is picking up now, he kept playing with this child, and we induced the child as he was playing. So, so pre-medication is one to do with anxiolysis. There are other reasons also why you pre-medicate the patient. Things like if you're planning to deal with a difficult airway or planning to do fiber optic, then you have to reduce secretions. Then you may have to give drugs like glycopyrrolate in appropriate doses like 10 mics per kg. And sometimes the few children are high risk for aspiration, and then you need to give drugs like ranitidine or prokinetic drugs. So coming to parental presence and no parental presence, I'm a very big proponent of parental presence. As you can see, this mother is such a big help to the team, and she is the one actually doing most of the job. And the child, she kept talking, and the child slept off with the inhalational induction. It goes unsaid that whenever you're planning for anesthesia, preparation is the most important part. Because of lack of time, I'm not going to go in detail of how to prepare for a theater when it comes to a child, but the basic steps like machine check, equipment check, making sure that's appropriate size equipment and their functioning are available. Especially in children, you have to ensure that OT temperature stays within the range. If you're dealing with a neonate, there should be overhead warmer to keep the atmosphere appropriate for the baby. Now, you have to load your drugs, both anesthesia and resuscitation drugs. They are very prone for respiratory complications. So we keep succinylcholine preloaded, and also we keep atropine preloaded because their cardiac output is heart rate dependent. You also have to remember the technician who is helping you with all the procedure, that person should be updated with your plans. Now coming to the how to induce a child. There are only two ways. One is inhalational induction, and other is IV induction. So most of the children undergo inhalational induction unless they have a IV cannula already in place because of some reason, either they are on antibiotics or some other medication which is going on, or the child agrees for cannula, which is a rare situation. Only the bigger kids allow us to put IV cannula, or they are high risk for aspiration. Whenever safety is you have to ensure that safety is taken care of, and then only the second step, comfort, comes. So in this case, if the patient is very high risk of aspiration, then you have to ensure that you secure IV and then induce IV via IV, and then you proceed with your anesthesia. There are some rare situations like malignant hypothermia where you don't want to give inhalational agents, or there are situations where inhalational agents are contraindicated. There you aggressively go for IV induction. If I may start off with inhalational induction, because 90% of our inductions are inhalational. So there are two drugs which are used commonly for inhalational induction. One is sevoflurane, other is halothane. Unfortunately, halothane is not available to most of us. If you look at two properties here in this diagram, one is blood gas partition coefficient, which is 0.69 for sevo, and halothane 2.5. And the reason why only these two drugs I'm talking is because they are the only drugs which are pleasant. All other are either pungent or unpleasant. So only two options exist really, sevo and halo. And now if you look at blood gas partition coefficient, for sevo is very low, whereas halo is high. What does it mean? It means the induction is faster with sevo, and the exit or emergence also is faster with sevo. So that is why we choose sevoflurane actually over even halothane. And halothane, as you know, sensitizes the heart for sympathetic stimulation, and then can cause junctional arrhythmias. And there have been case reports of arrest happening with halothane. So for various reasons, halothane has been now not available, at least to us. So we go for sevoflurane induction. So now other thing is important. You remember the child who may agree to undergo inhalational induction halfway through may decide not to cooperate. So you need to make sure the speed of induction is fast. And how can you do it? Use nitrous oxide. This is the only place where we actually use nitrous oxide. And the second gas definitely effect is, important and clinically significant. You also can use higher concentration provided the child accepts the smell. Though we say sevoflurane is pleasant, but when it's a day-to-day observation that once you cross 3% and 4% sevoflurane, then what happens is they start to kind of withdraw themselves from inhalational gases. Other things what you can do is, if the child is breathing anyway, a little bit they hyperventilate at this point because some kind of stress is there inside. Even if they are complying and they are accepting mask, but there is some stress at this point, and they seem to be hyperventilating most of the time. And you can add CPAP. This all will help in enhancing the speed of induction. So there are many ways of giving inhalational induction, and the first and most common is incremental induction. I will just show this video and explain as it goes. So we have our postgraduate who's explaining the process of inhalational induction. She is the mother. There's one more senior anesthetist and technician. So you can see for inhalational induction, you need 2-3 people around to help you. So this child is breathing, there's some leak, so mask really not fitting so well because he's keeping it very gently on the face. And as you see, nitrous is there in higher concentration, 4 and 2. And then slowly as the child accepts SIVO, the dial setting is increased. So there is slowly, dial setting has now come to 4 or 5%. She is still accepting, she's breathing all right. Mother is continuously holding hand and she's around and she's talking to her. And then slowly she sleeps off. Okay, once she sleeps off, further monitor apart from saturation probe is put in. So she is still responding to verbal, but actually she's, transition to anesthesia. So you can see 6% SIVO is there. So this is a technique of incremental inhalational induction. Once she sleeps off, mother goes out and then rest of the monitors are placed. Right now, there is only saturation probe. So that's one way. The other way is single breath vital capacity technique. We don't practice this too much because you need a lot of cooperation. Even bigger children don't cooperate so much. What really we do here, we ask the child to maximally exhale. And after that, take a deep breath hold. And then with one single breath, this baby or the child goes to sleep. If they are not able to take vital capacity, then you ask them to take at least 2 big breaths. Usually you need 5 years plus children to cooperate, but in our day-to-day practice, we don't see children cooperating this much. So this is almost, we rarely use this technique. Now, this is again one more technique where the children, their first case in the day, they come sleepy because it's a normal night sleep going on. And then we do steel induction. What really we do here is, we again give nitrous oxide in higher concentration for second gas effect, 4 and 2. And then again in incremental doses, we increase sevoflurane. The child keeps sleeping and we introduce masks. We introduce masks to the child and slowly come close. You don't go and touch because they are just sleepy. There's not a pre-medicated child. It's just a sleeping child. So if you go and keep the mask on the patient, the child will wake up and then he'll be the most uncooperative child. And you usually don't talk in your holding bay or operation theater because verbal stimulus also stimulates them and then wake up. Usually we talk to each other in sign language at this point of time. So you can see it's already 6% reach. And then we get the baby to the bed. Once we feel that it's deep, you don't have MAC. Remember, you don't have your MAC. You don't know really depth. So while transition, they usually move a little bit, continue to give mask, your inhalational agent, and put them to sleep. But there is usually with this transition, some movement happens, and that's when they, after that they go to sleep. So while you're inducing, remember few anticipated problems in specific children you have to be mindful of, like especially if your child is not deep and you're trying to poke in for an IV, or you're trying to manipulate the position or change the position, they can go into laryngospasm. Whenever the plane is not deep and the stimulation is given, there is always this chance of laryngospasm. So you must be aware. Remember, if you have not got IV, you must have a plan B ready, how to give succinylcholine in case the laryngospasm is significant. Also remember, their heart rate is very important, especially for the smaller children. Their cardiac output is heart rate dependent. So if you induce small babies or a Down's baby, where you realize that their tendency to go in brady is high, and if they land up in if you land up in a difficult IV, securing difficult IV, then you must have a plan B to keep your heart rate up, which is usually IM atropine, or you can also give sublingual. I have given IM atropine, I have not given sublingual atropine yet. Now, these are the various methods of inhalational induction. Now coming to IV induction, see, you need to remember one thing, children are needle phobic. I don't know whether they have so much of problem with that small prick, but they are needle phobic. They don't want to see needle coming close to them. So even if you put EMLA and prilocaine, it can work if you have explained enough, or it may not work because they're just scared of the sight of the needle. So you have to be mindful of these things. Just by putting EMLA doesn't ensure that your IV is going to be smooth. Obviously, if you have IV in place, then this induction via IV is very rapid and smooth, and nothing like it. It's very easy then. The drugs you use, thiopentone is a drug of choice for me, but it's not available, and propofol is what is available with us. Propofol, the biggest problem is the pain caused by propofol. Sometimes they cry even more than what they cried actually for the IV induction, IV placement. So the pain is quite a lot, and then you need to think about how to, look after this pain. You can give fentanyl, you can give lignocaine, either mix it or give before, after applying tourniquet. But remember one thing, the children don't allow you to do a lot of things on them. So propofol is painful, and usually even if you give them slowly and diluted form, they complain of pain. In our experience, that's what we have seen. And then relaxant use for IV induction is most of the time atracurium in children, and you plan for maintenance, which is usually isoflurane based until unless neonates, where we give sevoflurane. Now, another mode of induction which we must discuss is rapid sequence induction, or in a newer format, modified rapid sequence induction for children. So for this, the eligibility criteria is you need to have an IV in place. There are few components of rapid sequence induction. You have to pre-oxygenate. Again, do you remember in children, I don't have a video. It's very difficult to take a video for rapid sequence induction. So remember, children don't allow you to pre-oxygenate for very long time. Bigger ones do, the younger and smaller ones don't. So you give oxygen as much as you can. Then coming to the other component, what drugs you will give. Since we have propofol available, we give propofol. If you have thio is better drug. You can give thio and then give scoline. We do modified RSI, so we add some fentanyl to it so as to suppress the sympathetic response of intubation. And then your relaxant, which can be either succinylcholine, which is short-acting, quick onset short-acting drug, or it can be rocuronium, which is quick onset but longer duration drug. So it depends on what kind of patient you are dealing and what are the concerns with the patient. So Coming to cricoid pressure, there have been a lot of controversies regarding cricoid pressure because it seems there's a basic question, which is a basic fact which is under questioning, is that whether esophagus really is posterior to trachea, because the whole process depends on the very fact that esophagus lies posterior to trachea, and you can press cricoid and you can kind of squash this esophagus between the vertebra and the the anterior pressure. So now the evidence is showing that esophagus lies left to trachea, towards the left side posteriorly. So it may or may not be beneficial. Now in children, apart from this, there are many other issues, like the cricoid ring is really narrow. And what it means that your finger may be broader or wider than the cricoid, the cricoid width. So you are not able to give really properly the cricoid pressure. Second thing is the airway is really anterior. So if you give a lot of pressure on cricoid anteriorly, your epiglottis and the airway also gets distorted, which makes your intubation difficult. So because of various reasons, we don't practice giving cricoid pressure in smaller children. And then another important thing associated with rapid sequence induction is that you don't give bag and mask ventilation. But in modified rapid sequence induction, you can give a gentle bag and mask ventilation, but gentle means less than 12 centimeter of water. So you have to be mindful that you are not inflating stomach, and it's just a basic little chest rise is what you are looking for. Now, this was about our induction. Coming to intubation. So in very quick, in this slide, a short recap. You see the head is big till 2 years. So neck is generally flexed. So you need to put shoulder roll. The airway is anterior, which means the glottis is at the level of C3, C4, whereas in adults, glottis is at the level of C4, C5. You look here, the pediatric epiglottis is omega shape, and it can really cover, if you put your laryngoscope in vallicula, it can really close down and block your view. I don't know whether you're funnelist or non-funnelist, but if you believe that cricoid is the narrowest portion, then and the larynx and the airway looks like a funnel, then, or if you believe in subglottic is the narrowest portion and cricoid is the rigid ring. So in both the cases, you have to be mindful that if you're using cuff tube, cuff should not go and cause trauma, should not cause mucosal injury. Otherwise, it will land up in subglottic stenosis. So intubation, you need to put a shoulder roll in less than 2 years. Position is very important. You're trying to keep the nose and sternum almost, or chin or sternum almost at the same level. Here we are using cuff tube with stylet. Stylet has to be plastic. And we are using a straight blade in this neonate. And you can see how he's giving pressure with this little finger himself. So you don't need 2-3 people, because the baby is very tiny. You don't need 2-3 people, crowding here. You can do most of the things on your own. Again, this is just touching on whether you should use cuffed or uncuffed. Whatever you use, sizing has to be good. Cuff pressure should be monitored regularly. That needs to be always looked after. So your cuff pressure should always be less than, in neonates and all, less than 15 centimeter of water. Whereas in adults, it can be less than 20 centimeter of water. Now, with this, our induction and intubation is over. Now coming to maintenance phase. So maintenance phase, we cannot discuss too much here because there's no end to this phase. It depends on what your surgery is. It depends on what kind of patient you have. And based on that, your preparation will decide how, and preparation will be based on that. And these things will decide how your maintenance phase will go. So monitoring, apart from your standard ASA grade monitoring, which you can see here, this monitor is showing immediately after induction. You can see the MAC is so high. You can see baby is still breathing. And usually at the time of induction, we use only pulse oximeter, but immediately after we put all the monitors. And then you position your patient, and then your maintenance strategies can be inhalational based and paralysis based, maintenance of anesthesia, or it can be TIVA, total intravenous agents. It can be TCI, it can be only regional with some sedation. It depends really on what patient you are dealing with and what surgery it is. The important thing during maintenance time for a child, which we should never forget, is temperature. They have tendency to go hypothermic, and you have to ensure that room temperature, they have been pre-operatively warmed, intraoperative active and passive warming is in place. You can see his humidifier, you can see how is this covered, this all passive, and then there is a bear hugger going, so there's active warming going on in this child. So they are like literally mummified. In terms of fluid, again, based on what surgery it is, there's need of maintenance fluid, there's need of losses, fluid to replace losses. Whatever you do, you need to think about in very small children, whether you need to add dextrose or no dextrose. Even if you decide to give dextrose, usually 1 to 2% dextrose alone is needed. And the total maintenance fluid requirement is calculated by Holiday-Segar formula, and you really don't need the full amount of fluid to be given, because the babies are not in anabolic phase at this point of time, but they are in catabolic phase. So you need to give around 50 to 60% of total calculated fluid only. And the most important thing is how you give fluid. So if you're planning to give RL, which is isotonic fluid, you're using burette, and you are actually calculating, I need to give 30 ml per hour. So you fill your burette with the amount of fluid what you need to give. Now coming to analgesia, I will just, this is the only slide. Dr. Elsa is going to talk more about all this. So here you can see analgesia is very, very important. You can give systemically, but I will say for children, regional is very, very, very important. In our practice, we give around 90% of the patient gets regional. And the most commonly given block is caudal. As is shown, it has to be sterile, and you palpate and then you give, you aspirate. And in this child, you can see we are giving continuous epidural catheter, and he has undergone actually a major liver surgery. But you look at him, his FLAC score really look very low, and he is talking to his mom. So, you can really have major surgeries done, very comfortable patients after with the help of regional. Now coming to important part, which is now your surgery is over, maintenance, you did good job, now comes extubation. So if you see this apricot study in OR, it clearly mentions all the respiratory events like laryngospasm, bronchospasm, aspiration or stridor. The chances of them having in extubation period is far more than in intubation period. So it's so extubation period cannot be taken lightly, and the seniors should always be around during this phase. And then extubation can be done awake and can be done deep. Awake extubation is a safe way to extubate. Make sure your child is not coughing too much. Importance of this awake extubation is, even if your paramedic staff is not really, not paramedic, the staff, recovery staff is not really very equipped with the knowledge of handling a deep extubation, the child stays safe. So, and also if your experience is limited, then you must ensure that you keep the patient awake all the time. And only thing with this is, do not allow these patients to cough on tube. So if your analgesia is good, and if you know how to extubate at when MAC is around 0.2, they do fairly well. Now, deep extubation is an art. I have just kind of, I'll show you this video. Deep extubation means your patient has to be really deep, MAC of around 1.4. You can see this patient is already on PSV Pro mode. He is 8 kgs and he is almost, the tidal volume is 9 ml. So he's breathing very well. Stimulus, he's not responding. Keep always an eye on respiration. So, all these things are taken out, but this baby's breathing pattern is not changing, which in itself is telling us that he is fairly deep. So once you are done that, if you are doing even the intubation, also if you're extubating a endotracheal tube, also the same process you follow, and you always keep an eye on respiration. Once you are done this, give a good deep suction. Make sure you're happy with the respiration extubation criteria. Make sure you're giving high FiO2. It doesn't mean you have to give 100% FiO2. You can see here we are giving 70% FiO2, and then your MAC is still deep, 1.2. Okay, and he's breathing quite fairly all right. Respiratory rate is okay. Hemodynamically stable. And we are really dropped down to 6 pressure. And then you extubate, he's breathing, and then you ensure that sometimes you need to give jaw thrust. So you support the airway, take out the monitors, and shift the patient. Important thing here is once you shift the patient, you still should have your ISO running. You see, where we are cutting off ISO only after shifting the patient, putting the patient in lateral position, making sure airway is all right, and after that we cut. So no stimulus should happen in lighter plane. Otherwise, this patient will have laryngospasm. So really, deep extubation is an art. So I'll show you what happened in this patient. In this patient, what we have done is, patient was extubated deep. While transferring, they cut off the gases, and by the time they shifted the patient and turned the baby already started breathing like this. So then they have to turn the patient from lateral to supine and give CPAP, and then only laryngospasm was broken. So what goes wrong? So if you're talking about deep extubation, there can be no stimulus in lighter plane of anesthesia. Everything has to be done in deep plane, and then recovery nurses have to extubate this patient with almost no touch technique. The patient has to wake up by themselves. And if you have not done a good suctioning, then the secretions still can cause laryngospasm. Even if the patient has kept no touch, the secretions can cause laryngospasm. So you need to give a good suctioning before you call it a deep extubation. If laryngospasm happen, always remember, give oxygen, deepen the plane of anesthesia by giving propofol 1 milligram per kg. Make sure, just remember, you have laryngospasm. Deepening deepening the plane by inhalational agent may not work that well. So because you anyway have IV access at extubation, give IV drugs, and then you continue CPAP, make sure airway is patent. If they still continues to desaturate, give succinylcholine. Do not hesitate, give succinylcholine and break the spasm. Only thing is, with succinylcholine, you may sometimes see brady, because you see patient is desaturating, you are giving scoline. Both the reasons can cause brady. So you may have to give atropine at this point of time. And remember, you are not trying to intubate this patient, you are just breaking spasm. So the dose of scoline is only 1/10 of the intubating dose. And the patient after this starts breathing. If you have not managed laryngospasm immediately, you must look for negative pressure pulmonary edema. If the laryngospasm is very severe and it's a complete laryngospasm, you have to monitor this patient for negative pressure pulmonary edema. There's another, if you look at this algorithm, everything I mentioned. Now, if you are having desaturation after laryngospasm, there are two ways to go. One, either you deepen the plane of anesthesia, or you give Larsen maneuver. So we have seen many times, you deepen the plane of anesthesia, then people start giving Larsen's maneuver, and they say Larsen's maneuver can be given. So you cannot be deepening plane of anesthesia and stimulating patient at the same time. So Larsen's maneuver, if you choose, you go this path, and then you give a good pressure between stylet and mastoid process. And the idea is abductor muscles of the vocal cord get contracted and they relax, and then they open up. That's how it works. So once you have extubated, everything is all right, you need to also think about transporting this patient from your theater to recovery room. Ideally, recovery room and theater should be very, very close. Before you shift the patient should be hemodynamically stable, airway should be patent, you should be happy with oxygenation, there should be no bleeding, no other issues, and then you shift this patient. And if your recovery is very far from your theater, then you have to have some kind of monitoring, and you need to have some oxygen going in this baby. So transport is very, very important. Once you have transported the patient to recovery room or PACU, post-operative anesthesia care, then recovery starts. So the recovery is usually there are 3 phases of recovery. Early is what we anesthetists are actively involved with, where awakening and recovery of vital reflexes are happens. And then there's something called immediate recovery, where the patients are in the ward and they are now getting ready to be discharged to home. And late recovery is the recovery time period when the baby or the child comes back to his full psychological, full physiological and psychological recovery happens for the child. So these are 3 phases. We are directly involved with the early phase. Remember, you should not forget about your patient after you shift the patient to PACU, because very much in PACU, the responsibility of patient is really yours. So, PACU should have dedicated nurses. They should have basic knowledge about airway, BLS. They should be able to identify critical events and call for help. And the ratio of nurse and patient in PACU is usually 1:3 because they are mostly stable patients. What I mean by sick patients where you need 1:1 care is that, let's say you have removed a foreign body, there are multiple manipulation in the theater, you're expecting airway edema. This patient, when it comes to recovery, should be monitored by one nurse all the time. So this is just a small video to say, how we shift our patient. She's dedicated recovery nurse. He is our anesthetist. They have shifted a deep patient. They have put in pulse oximeter. They are monitoring pulse oximeter. And after that, they are trying to place a ECG. So in early recovery period is very, can be very happening, and you must watch for post-operative complications. They should be under close monitoring by these dedicated nurses. Then in recovery, this early recovery phase, we think about feeding, especially the smaller ones who are on mother's milk, and this 1 to 3 age group who starts to become very jittery if you don't feed them or you don't give them water. And there is a very important role of parents in early recovery, because their presence actually calms the baby down, and then everything goes smooth. And then once they meet discharge criteria, they are shifted to ward. So in this recovery phase, you may see common complications. You may see complications, especially the respiratory complications like laryngospasm. I'm not going to talk now because I've already covered it. Airway obstruction. They may be hypoventilating because of anesthesia drugs. Post-operative nausea, vomiting is the most common recovery room problem. Then they may be hypothermic. They can be emergence delirium. These things can happen in recovery. So it is really a very happening place, and you have to be very careful. Remember, it is not recovery room responsibility, is anesthetist responsibility, and you are helped by the dedicated nurses. So airway obstruction, they present like a seesaw breathing pattern. There'll be intercostal indrawing. There'll be retractions, either substernal or suprasternal. And how do you prevent it? Ideally, you should have put this patient in recovery if they are deep, or some airway, Goodell's airway or nasopharyngeal airway has been put earlier. The culprit for airway obstruction is most commonly tongue, but also epiglottis. How should you position in recovery room? It should be recovery position. But if the patient is supine, then you should, less than 2 years, you should have a shoulder roll. And I'll show you why you should. I just notice that there is no shoulder roll in this baby. And you see, we are doing fiber optic, and see, this is how epiglottis lies. And epiglottis is another level of obstruction. So one is tongue, other is epiglottis. So look at this video where jaw thrust is given, and you can see how does epiglottis look. See, epiglottis, you can see an open airway here. You can see a nice open airway. This is because of jaw thrust. And the third video you see, there is a shoulder roll. So in shoulder roll, you see how does epiglottis look. See, there is still an airway. You know, you can see that clearly shoulder roll is helping, but the best thing is to give jaw thrust. But the problem is you can't give jaw thrust in recovery because the child is now waking up. He may not allow you to give jaw thrust. Again, handing over is a very, very important thing for recovery. So whatever has happened in theater, you have to tell recovery nurse, because let's say you have this patient where you have multiple attempts and of intubation, they've been airway edema, and you don't hand over this patient properly, and you don't tell nurse to give adrenaline nebulization as per age. You have not given IV DEXA, then the patient obviously will undergo a post-extubation stridor. So handing over is important. You must anticipate problem and you must initiate treatment even in theater. Like IV dexamethasone can be given immediately in the theater. You should bring this patient with oxygen supplementation, and you should have given a clear-cut instruction of adrenaline. Let's say if it's a 10 kg baby, you will say 0.5 ml of adrenaline diluted in 3 ml of normal saline should be given to this baby, and you have to document it. Now, this is another common problem which is actually seen for the first time in recovery room when the patient wakes up, nausea, vomiting. We must know that children have higher incidence of nausea, vomiting than adults. And this is really also sex dependent, age dependent, and surgery dependent. So the incidence of nausea, vomiting can be as high as 50%. As you can see. And the common surgeries, the common culprit surgeries are strabismus, tonsillectomy, and then you have orchidopexy. Once you have nausea, vomiting in recovery, you have to ensure that patient does not aspirate. So put them in head-low position, recovery position, give them antiemetics, 2 drugs antiemetics like 5-HT3 and 5-HT3 antagonist, ondansetron 0.1 milligram or 0.15 milligram per kg, or you can give dexamethasone 0.15 to 0.2 milligram per kg, you can give. Now, apart from post-op nausea, vomiting, a common, not common, but another important complication seen in recovery is emergence delirium. Incidence is as high as 10%. The best thing about this thing is a transient phenomenon. It resolves on its own, but it takes around an hour. What exactly is emergence delirium? It is a mental disturbance during recovery of general anesthesia. Child faces hallucination, delusion, is confused, restless, moaning, and thrashing around. The problem really is because they thrash around so much that they can actually injure themselves. And it is our job to ensure that they don't injure themselves. And there are various assessment score like PEAT score or VACHA scale, which you can follow. And you can anticipate whether they are going to undergo or they are undergoing emergence delirium. The drug treatment choices, dexmedetomidine 0.3 to 0.5 microgram per kg. You can also give propofol 1 milligram per kg. Now, these are the common problems you see among children when they are very small babies, like you're dealing with a premature baby who's coming for hernia repair. You know, also these patients are recovered in recovery room. So you must have some idea about the complications they can have in recovery. So I will not touch too much upon this. Only thing I will say is apnea of prematurity, which means cessation of breathing for 20 seconds or even less than that with the desaturation and bradycardia, is a significant apnea of prematurity. It is seen with preterm, but also can be seen with term baby who are sick. And I will stop here because this will take it, otherwise it will take long. Now, Now coming to once you have watched for complications, the children are waking up, and you have to ensure you feed them. This by default order of give them water after 4 hours is not a good practice. In fact, this age group children, as you can see on your left side, these children actually need water immediately, and you must give them. If they are on mother's milk, you must give feed to them, and it really increases the satisfaction score among children and parents both. You look at this girl. This girl had MRI 15 minutes back. You see, she's so wide awake. Is a propofol. So she has got 15 minutes back MRI. You can see she's already taken half glass of juice, and she's up and above ready to go. So you can discharge them in 15-20 minutes. So this all can be done. So take home message will be, you have to, recovery period is a continuation of your anesthesia. Responsibility is yours. You have to anticipate complications, and PACU facility, in case you don't have similar PACU facility as that of OR, you must recover your patients in OT. And the trained nurse are very important for PACU. So once they get their modified elder score more than 9, you can discharge them to ward. So is that all? Once you shifted your patients to ward, remember to follow your patients. You should have some kind of acute pain services. If not dedicated, then you must go back and see your patients and look for analgesia management. And remember, if there is any mortality in 24 hours after anesthesia, it is anesthesia related. If there is mortality in child within 24 hours, it is anesthesia related mortality. Also, very important topic that you need to always remember, for which the parents are always worried, is the effect of GA. So you must be ready to answer these kind of questions also. So now you must be thinking, why suddenly I've moved to chicken biryani? The reason being, one, time is going up. Time is up for me. And the other thing which I want to kind of tell from this slide is, the chicken, the rice, and the masala are same, but you can have various ways to make your biryani. And not that Arkat biryani is the best biryani or the Hyderabadi biryani is the best biryani. All biryanis have their own taste. So your anesthesia planning can vary, and it must vary, because variety is good. But your basic steps should be safe, and you must ensure the safety with your basic steps. And frills you can add, and you can have your own kind of frill to your child's management. Planning and communication is the key, and anticipating problem even before the problem is occurring. So anticipating problem is very, very important. And with this, I will end, and I'm happy that I finished on time. Thank you.
Excellent lecture, ma'am. I really enjoyed it. So good. It was like we have to have a lot of experience to learn all this. You got everything within this 45 minutes. Especially when I was doing PG and this EMLA cream was marketed, I used to think it is going to become easy for me to put a influence. Then is the time when I realized that the child is not afraid of the pain; it is actually afraid of the needle. Really nice lecture, ma'am. Especially the last slide in biryani. We'll take up some questions, ma'am. Shall?
Yeah.
Okay. There is one question on how you take up an IV line. Is it before or after induction?
So if they allow us to put IV line, we put IV line, but 90% of the time they don't allow us to put IV line. So it's always for me, I think I will say after induction.
Okay, ma'am. There is one question where whether if you use oxygen nitrous oxide together during induction, won't it cause hypoxia?
No. So if you're giving the nitrous oxide, so you're not giving 100% nitrous oxide. You see, remember 21% is the oxygen in your atmosphere. So if you can give 33% oxygen, you're still giving higher oxygen.
Nice, ma'am.
21%. So, but if you really want to get second gas effect, you need to have higher concentration of nitrous oxide. Otherwise, it will not work.
Okay, ma'am. If you had the choice of having all the induction agents, which would one do you, ma'am? Because you said Thio, it is not available with you. If you had the choice of everything, what would you use, ma'am?
I will choose Thio. I will choose Thio because I think what I notice every day, they scream. The children scream more when you give propofol than actually you hold and give IV. It's very painful.
There is one question regarding the ventilator settings for children, ma'am. The mode, the tidal volume, the settings.
So I think protective lung ventilation still holds true. Only one thing I will say here, one very important fact which we forget is on your ventilator, the numbers which are shown at the machine end. The numbers, they are at machine end, not at patient end. So if your monitor, the ventilator showing for a 8 kg baby, 80 ml, it is 80 ml at machine end.
Machine end.
And then you have a circuit. This circuit is very pliable. Every time if you keep hand on the circuit, if you give inspiration, the circuit actually dilates. So there is a loss of tidal volume there, which you have to keep an account. And we have been very, very lucky to have many monitors. So your ETCO2 will tell you, that you are giving adequate tidal volume or not. Your saturation will tell you whether you are adequately ventilating. And that's it, I think. Yeah.
There is one question on single vital capacity induction, ma'am. Have you tried it? What percent should be used?
I have not tried. I have tried convincing bigger children, and what I have seen is they don't take that vital capacity. So for me, I think maybe inexperience or whatever, I have not been able to convince children, one, to take that vital capacity. They become very restless. The more you give instructions, they get restless.
Exactly, ma'am.
So I have not got experience in this.
There are questions, two questions on sublingual succinylcholine, ma'am. The first is on the dose, and the second one is that if giving sublingual, won't that cause a laryngospasm?
That's very good question. Okay, so dose is simple to answer. It's equal to IV dose. It's equal to IV because the sublingual part is very vascular, so it acts fast and it's like an IV. And now coming to the second bit, yes, obviously you're stimulating in lighter plane. But I think you are now, when you are talking about succinylcholine, you already reach a stage where deep saturation is happening. You have already tried FiO2 of 100%. You have already tried CPAP. You've already tried deepening them. Nothing is working. So that is the only way to break the spasm. So I think just go and give.
Yes.
Just go and give.
Okay, ma'am. There were questions on antiemetic and emergency relief. Both were covered very nicely in your lecture, ma'am. Especially the time to feed the child. It's really a very difficult area to assess. You had covered it very nicely, ma'am. It was a wonderful lecture. Thank you very much, ma'am.
Thank you. Thank you.
Thank you. For the next part of the lecture, to talk about the regional anesthesia and children, we have Professor ELSA VARGHESE, ma'am. Welcome, ma'am.
Thank you.
ELSA, ma'am. She has been a former professor and HOD of Kasturba Medical College, Manipal. She has done her DA and MD anesthesia and CMC Vellore and her pediatric anesthesiology from Dept in USA. She is worked as a senior consultant at MIOT Chennai, and she has been the past president of IAPA. She has had a lot of publications in her name, and she's an eminent speaker, more than 100 conferences, and that too very elite orations she has given. We are proud to have you here, ma'am. We are waiting to listen from you. Welcome, ma'am.
Thank you. So, good morning, everyone. Can I just share my screen and just tell me whether you're seeing it?
Yes, ma'am. Yeah.
Can you see my screen?
Yes, ma'am. It's visible.
Okay. And can you hear me?
Yes, ma'am. Clear, ma'am.
All right. So if you don't mind, if you can just put yours on mute because I can hear the sound from your
Yes, ma'am. It's
operating
been
room. Yeah. Well, good morning, everyone. You've had such a profound and wonderful lecture. You practically learned the whole textbook of pediatric anesthesia from EKTA, Rai, and peppered with so much of experience. And today I have been asked to talk about another whole textbook of regional anesthesia in children. And I'm going to just run you through it. And obviously, when you want to do a block like this, you have enough material available for you to check on it before you proceed. And that is absolutely important. So actually, what is most satisfying for all of us is that you have, after surgery, is when the child can sleep peacefully and without pain. And that is really, I mean, you've given your anesthetic well, but what the parents and what the child suffers in the post-operative period actually can all go be annulled if you have not provided what is now considered an absolute vital sign of pain and its treatment. So I'm going to dwell on that topic, and I hope to cover some of the relevant anatomy, physiology, and pharmacology very briefly. We will then talk about some of the central and peripheral regional anesthetic blocks, when you do it, how you do it, what kind of doses. And then we need to also remember that each technique that you use is invariably associated with complications, especially if you cut corners and if you're inexperienced. And very briefly, if I have time, I'll cover some of the controversies. So let's plunge right into the anatomical implications. And I'm sure all of you are aware that basically the spinal cord in a child, in a neonate, can extend, or the conus medullaris extends right up to L3. And in adult, it shrinks up to L1. And what actually happens to the dural sac? You see that in a neonate and in a, it's right up there, almost up to S4, and goes back up in an adult to S1, and this is reached by the age of 1 year in a baby. So what are the implications of this? That because the dural sac ends at S3, S4 in neonates and infants, one has to be very cautious, especially when you are providing a caudal block, because you can actually, you think you're injecting your local anesthetic into the epidural space, but in fact, it will go into the subarachnoid space, and you can, since you're giving fairly large volumes, you can create a total spinal. So it's important to know that. And also important to know, especially when you provide epidural anesthesia, is that, say, if this is in an adult, you'll find the spinous processes are much more inclined, and which they're far more parallel in a child. So it's actually easier to go by the midline approach when you're providing either a spinal or a new epidural block. Let's talk about some of the other implications. When you look at the sacrum and the sacroiliac, sacrococcygeal ligament, it's much wider in a smaller child. So actually, that's like a magical availability for us as anesthesiologists, which is why this caudal blocks are probably one of the most common and most popular blocks, because they allow easy access to the epidural space. And another important thing to remember is that though as we all know, there is fat and there are fat globules in the epidural space, but the fat is far more liquid in children less than 8 years of age. And what is this? What is the implication of this? It basically is that when you inject local anesthetic, it spreads much more, and it aids in the extensive spread of the local anesthetic. Another important thing is actually when you look at the amount of relative volume of CSF in the subarachnoid space, it's far more in a neonate compared to an adult. And therefore, the implications are, like, especially if you're giving a spinal in a smaller child, is that actually you need a higher dose of your local anesthetic because it immediately gets diluted. So if you're using, for instance, a hyperbaric or isobaric 5.5% bupivacaine, it's very rapidly diluted, and therefore you have a shorter duration of action. And the important thing is, you can use this technique, especially in infants and neonates, only for very brief procedures. So it's important to know why. That's why I'm highlighting this. When you look at the actual anatomy of nerves, you find that how do you access the spinal space for central block? You find that the subarachnoid space, if you go by, like what we're classically taught about the intercrystal line, it may not, what we found when you actually check with ultrasound guided techniques, is that it may not necessarily, the intercrystal line that we use may not necessarily correlate with the actual space. You might actually be, it might actually be lower than you think, or it may be higher. So you can't really go by that. It's not very accurate. The other important thing to know is that actually when you look at a newborn, there's almost like a single curve at birth. And what happens by about 6 to 8 months, you start getting the cervical and the lumbar lordosis, and it reaches this by 1 year. So basically you don't have to, the positioning is much easier for when you're doing a baby. Now, another aspect that I would like to stress, especially when you say you're giving blocks which are close to bones, like epidurals and like caudals, there is incomplete ossification of the bones. In fact, a neonatal bone is so soft, and you might actually, when you're giving a caudal block, actually go right through the bone, and you may not know it because there's less resistance to needles, and you can actually cause damage to ossification nuclei. So this is another, you have to be very sensitive. Your fingertips have to be very sensitive to a pop or a change. And now with ultrasound guidance, you can actually see what is happening. So about actual nerve structures, for obviously in a baby, the nerves are smaller, vessels are smaller, tendons are smaller, and there's much less adipose tissue, and the structures are very close together, they're very superficial. So the implication for us is that they actually cause potential injury to the nerve itself and surrounding structures. And this is where, as Dr. EKTA was saying, with ultrasound guidance, it's amazing how you're actually seeing what you're doing, you're seeing where the actual tip of the needle is, and therefore you end up having less injury. Now, there is less connective tissue covering on the endoneurium. The actual diameter of the nerve is smaller, and the myelin sheath is incomplete. And the implication for us is that you don't have to wait so long. You almost have an immediate sensory and motor block, and you can actually use lower concentrations of your local anesthetic, and this can give you prolonged blocking. So these are all very important anatomical differences and the implication for us. In terms of physiological differences, we all know that the pain perception is very acute, right, in a neonate, in a fetal itself. But these babies have poor localization, so you can't really use a pinprick technique or whatever to find out where the actual pain is. And and the descending inhibitory pathways are not really developed. So, there's suddenly confusing inputs. And there is a marked stress response to acute pain. So, you may think that post-op pain, what's there? The child's going to be okay in 2 days, but there is a recording in the brain, and it can actually cause a risk of chronic pain syndromes in children, and which you can't really ignore. So you have to understand that the implications of pain are really very acute in a child. And we all know, I mean, if you have a child or you yourself have had a painful procedure in your childhood, you're never going to forget it. And so there are secondary problems to this. So therefore, it's so important that preemptive management of acute pain is an absolute armamentarium that you follow. And therefore, regional blocks play such an important role. When you think of other physiological implications, we all know that the enzyme are less available and they're inadequate at the breakdown of the drug. So you have longer duration of action, there's less protein binding, so there's more drug available. And this is really important because if you're giving repeated doses, either for epidural procedure or with continuous local anesthetic infusions, you actually have an accumulation of drug and a tendency for toxicity. What the good news is, like for instance, you do not get as significant a hypotension after a central neuroaxis block, especially in the smaller children, because there's reduced lumbar sympathetic efferent component. In terms of pharmacological differences, this follows on from our physiological differences. And as I've already mentioned, you have a faster onset, shorter duration of effect, and it comes on. The onset of action is faster because, again, you have a increased cardiac output. And because of that, it's distributed faster, and so it has a shorter duration as well. And because of the low protein binding, you have the free fraction available. And this is why we talk about local anesthetic systemic toxicity, for which the immature enzymes or metabolism, they don't break down the drugs, and therefore children are prone to it. I know this is not a very common phenomenon, but since we as anesthesiologists give regional blocks, and we're doing them more so than ever before, we have to be able to recognize this and treat it promptly. So what are some of the contraindications? Let's talk about that. Which of the children you are not going to give regional blocks to? I don't know if any of you have had parents who've said, no, I don't want my child to have. I've had at least 4 parents who I've explained, I'm going to give a block once the child is asleep. And they said, no, 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 don't go anywhere near the spine. We don't want that. So you have to get consent. It's not just getting consent for GA. If you're giving a block, you have to say, I'm going to be giving a block as well. You need to make sure that where you're giving the block, the skin is fine and there's no infection. And for instance, when you talk about giving a nerve block that might hinder the surgery, I know there are some surgeons that are working on the penis, if they're doing for hypospadias repair, etc. They feel that if you give a caudal, that it causes engorgement of the penis, and they say, no, don't give it now, give it later. So you have to be aware of what some of the surgeons like and what they don't like. Okay. So relative contraindications are, for instance, I'm sure all of you have been taught that if there's dimpling or if there's a hairy area around the sacral hiatus, don't give a caudal block. So that is true, but now with the onset of and the use of ultrasound, you can actually check is there any underlying neurological abnormality, and based on that you can decide whether to proceed or not. Obviously, if the bleeding disorders or if the children have basic neuropathy, then you have to be concerned about post-op worsening, because then you're implicated on your block. As you know, and you already know, most of you, anyone who's had a spinal or an epidural, if they've ever had backache, even 20 years later, they say, remember, I had an injection in the spine, and it's because of the anesthetist, and that's why I'm having the pain. So you have to be very careful. Sepsis, it's important to know, it's not just local infection, but also if the child is in sepsis, it can actually start push infection right into a neural space and make it CNS infection as well. So generally, even in adults, if then sepsis, you try and avoid the spinal. So if you do have any new neurological deficits, then you need to be aggressive and go ahead and do some imaging to ensure that it's not related to your block. And for this, the important thing, as Dr. EKTA mentioned, is you have to follow up your patients, and you've got to know, always ask your surgeon, or he should tell you if there's been a problem related to your block. So we all know, but I know there are some people who skip some of these basic things, so I can't emphasize that you have to use sterile techniques. What the book says that you preferably use chlorhexidine over povidone iodine. It's important that for whatever procedure you're doing, you use the appropriate needles so that you don't cause damage to the nerves. For instance, when you're giving peripheral blocks, and you have appropriate needles for epidurals, for caudals and spinal. And more importantly, don't try tricks on a baby, especially a small child. Watch somebody who has experience and only then proceed. And one of the crucial things is that the known fact that there are more complications when you have inexperienced anesthesiologists providing regional anesthesia for children. And it's so important that you follow the rules and position patients appropriately for the procedure. So let's go into the common neuroaxial blocks in children. I think most of you would have seen caudal blocks. Those who are more experienced working in larger centers do epidurals as well in small children, right from neonates up, and spinals especially in newborns. But I do know that there are several centers that are providing spinals even in older children under sedation. So let's walk ourselves very briefly through this. This is probably the most commonest block that most of us have followed. It was hardly ever used earlier, but probably from the 90s it started becoming very popular because it's such an easy technique to use and relatively safe. And so you would use this basically when you want to block anything below T10 dermatome. And we all use it for urological procedures, lower abdominal surgery, pelvic and lower extremity surgery. What are the important landmarks? It's really, you feel for the posterior superior iliac spines, and then you imagine a equilateral triangle defined by these two spines. And this third angle usually lies over the sacral hiatus. So you palpate both the sacral conus at this location and you will feel a little depression. And that's when if you look at the ultrasound picture, this is the sacrococcygeal membrane. So your needle will be coming in at an angle, and then you would flatten it so that it goes into the epidural space. Here you're seeing the conus of and this is where you can see the dura ending. So that is the advantage when you use an ultrasound, that you can actually see. So what I was saying, let's say you have a dimple here or a hairy, some hair, then you put your ultrasound flow probe and put it in a linear sagittal plane and in the midline, and you can actually see the dural sac. And so you know that you have a safe space to inject your drug. So most of us don't use ultrasound for when you're doing a caudal, but it does give you information, and you can actually see where your needle is. What is preferred is that you use a stiletted needle, but a lot of us use cannulas. It goes through the space, you get a distinct pop, and then you inject your drug. And depending on the level that you require, the volume is what is recommended. Obviously, the older the child, but they don't recommend you give more than 30 ml as a total volume. And lower concentrations are what has been recommended, because remember, the epidural space is very vascular and you can have a rapid absorption of these drugs. Nowadays, most people prefer ropivacaine over bupivacaine, though because of the cardiotoxicity of bupivacaine, though you must remember that bupivacaine also can cause problems. And if you have the fortune of, like in Europe, of having levobupivacaine, then that has less of cardiac toxicity. However, it is extremely expensive. Now we move on to epidural blocks. These are blocks that need to be provided by experienced anesthesiologists, and there are clear indications. You can, for thoracic surgery, for instance, large centers, they even provide epidural anesthesia for tracheoesophageal fistulas, etc. But those are people who know how to do it and they know the safe techniques. So you can give for much higher, and you can actually have selective blocking of nerves. But one has to be very cautious. You can give single shots, you can give continuous infusions, and in an older child, patient controlled as well. There is a significant role in patients with cerebral palsy and those with asthma or respiratory diseases, because you're going to be using less of your general anesthetic, etc. Now, one word of caution, which when we talk about controversies, when you have children who have total pain relief, sometimes, especially if they're having procedures on the lower limb, if you have no pain at all, you may not, one of the earliest signs of compartment syndrome is pain. And so there are some controversies that if you provide total analgesia, that you may not be able to actually pick up the compartment syndrome. However, this is again being questioned. And it's so important that we do provide these children with adequate analgesia. So let's talk a little bit about epidurals. As you're pushing your needle in, and it goes just above the space, just superficial to the dura, and you can thread your catheter up. You have to use sterile techniques. And in children, even though it's under general anesthesia, for epidurals, it's important you do use a test dose. And so you can position the patients accordingly. But the important thing is that, actually the angulation is not so acute as in adults. And you use loss of resistance technique. And what is emphasized for children is that it's much safer, especially in smaller children, to use air for loss of saline for loss of resistance rather than air. And there are obviously risks associated with epidurals: puncture, bleeding, infection, urinary retention, etc., and nerve injury. Pediatric epidural needles, they can get special sizes, they're shorter, and they have more frequent markings at 0.5 centimeters rather than 1 centimeter, as you see in adults. Now, in terms of depth, usually you reach it within a centimeter or maybe even less. Here, it ranges from 0.4. So, you have to be very, very cautious. You can go right through and damage the spinal cord if you're going at a thoracic level. And in older children, you go by about, say, 1 millimeter per kg per body weight. The test dose that is highly recommended, and you need to wait for an adequate response. And what is the response? Even if you're using sevoflurane, you need to remember that if you would get a transient increase in heart rate or blood pressure, but these are not very accurate. And within the first 30 seconds, you can see an increase in height of the T wave. So when you are giving an epidural, you have to have your monitor right in front of you, and you should be able to see it as you're injecting, because it's so transient, you might miss that you are actually injecting into a vascular space. So you can give continuous epidural analgesia at various levels, and you can insert the Caudal catheter, also there are a lot of people who insert the catheter into caudal space, and under vision, they push it up to whatever level they want. But one needs to remember that they can go wind around nerve roots and cause problems. And you can add additives as well. And there's standard dosing parameters that you use for neonates, for infants, because you want to avoid last. And remember that every time you're giving a top-up dose, you have to also aspirate. So the initial bolus doses for younger children is a little different from those who are more than 10 years of age. And what is recommended is that you use lower concentrations of bupivacaine. And for thoracic epidurals, you kind of halve the dose of what you would give for lumbar epidurals. And if you're giving a repeat dose, like you don't have pumps and you're giving repeated doses, your repeat dose is half the volume of your initial volume, and you need to give it about 2 hours later. And if you're giving a continuous low dose infusion, you go down to even lower concentration. And important to remember, as I'm stressing again, that there is drug accumulation, and so you need to look out for toxicity. So there are complications related to catheter insertion, so you avoid pushing it too hard, and you need to evaluate the progress. And it's unclear whether ultrasound is better than dye, but you obviously you don't want to throw too much radiation to a child. So if you have ultrasound in your room, better. The common drugs that we use are bupivacaine and bupivacaine. An important thing to know is when do you stop it. If you're giving a continuous infusion, if you're using bupivacaine, you don't usually recommend its use for more than 48 hours if the child is less than 6 months of age. And ropivacaine, you can have it for a little longer, 3 days. If you have levobupivacaine, you need to use it for a much shorter period of time. Otherwise, you can get problems with overdosing. Adjuncts, we use almost 60% of pediatric anesthesiologists use additives. And the reason they do so is to prolong duration and improve the quality of the block. And the common drugs that they use are clonidine, ketamine, and fentanyl, but you do kind of need to avoid these drugs in neonates as far as possible. And there's no advantage of most of the other drugs that have been tried. So complications are similar, and but there's a lower rate when performed under ultrasound, and the risk of long-term complications most have been found in when you use ultrasound, that the complications are much lower, almost reduced by 50%. And if the important thing is if there's hepatic dysfunction, cardiac dysfunction, or dehydrated child or hypoproteinemic child, you need to cut down the dose of your drug. Okay, so if there are serious complications, the one we worry about most is last, and I won't go into how we treat it. The good news is that very rare complications, what we see is commonest, and even that, not too many cases of last, respiratory depression, mainly when opioids were used, no cases of hematoma or permanent deficit. One case was reported of epidural abscess. These are the doses, but I suggest you look it up of what is the initial dose, infusion, but generally they range between 1 to 3 mics per kg for bupivacaine, and infusion doses is half that, and or even lower ones if you don't want motor block. Right, we talk about spinals. Now, awake spinals, these are mainly performed in neonates and sick preterm where you don't want to give a GA, and surgery of the lower abdomen or lower limb. We found that there were a lot of children who used to come with abscesses, who've been have with sepsis, who have abscesses that need to be drained, neonates, because they've had so many procedures in the neonatal ICU. So we used to give that. And you need short needles and for 25 gauge, and you go in at a lower level, as we mentioned before. It is an underutilized technique. Not many centers use it because you require an experienced anesthesiologist. You require a very good assistant to hold the baby. You can either do it in the lateral position or the sitting position, or some centers use the frog position, and that the bottom doesn't move and you don't have a moving target. We usually put a little bit of Emla cream a little bit beforehand so that the baby you don't have to give toe pokes. And infants tolerate this well, and there's not much of a hypotension. There was an interesting study where they studied about 500 neonates in infants, where they provided spinal anesthesia, short duration, and very low complications rate. And I just need to point out that when you're positioning the baby, you need to avoid lifting up the legs, because that's when the level goes much higher. So don't keep the head down and the legs up, especially if you're putting a cautery plate or whatever. You need to be very careful about that. And remember that if you're giving a sedative along with this, you're likely to have apnea. So not easy to do these blocks. And so you need to avoid multiple attempts, because you can get bloody taps, total spinals, etc. So a lot of people are moving rather from spinals to caudals in neonates. We have a higher success rate. Dosing is, as mentioned here, we use mainly bupivacaine, and you give more in the older child. Okay, well, so what are the big benefits of regional anesthesia? Basically, you're reducing opioid use, much less nausea and vomiting. As Ekta said, these children, a retching child, is just nothing more distressing. And if you look at feedback from parents, most of them say that, the nausea and vomiting was so distressing for children. And they reduce the post-op pain scores, much less respiratory complications when you have with opioid sparing. And as mentioned earlier, there's a huge stress response in babies, and this reduces the stress response, and therefore the immune response is better, etc. It reduces the MAC of your inhalational agent, and it also facilitates early and smooth extubation. And if you have, a child, you've cut down on your anesthetic, you're waking you up, the child already is pain-free. So they've got early post-op pain relief. So we now move on to peripheral nerve blocks in children. Now, there were not too many peripheral nerve blocks being performed. Some head and neck blocks like infraorbital block for cleft lip and palate, and palatal blocks for palate. But otherwise, maybe ilioinguinal, iliohypogastric, but not and maybe supraclavicular blocks. But there's been a huge flood of new blocks that have come up ever since the use of ultrasound. And so the role of these peripheral blocks in multimodal pain control, especially for extremities and lower abdominal incisions, play a huge role. So let's talk a little bit about the truncal blocks. Now, these are indicated when you have surgery around the umbilical area and abdominal surgery. And so there are 3 blocks that have become popular now: rectus sheath block, transverse abdominis plane block, or what we call the TAP block, quadratus lumborum block. So we'll be talking a little bit about this, and they're fairly easy to give and very low complication rates, especially when you're providing them under ultrasound guidance. So let's talk a little bit about the TAP block. So here you have the child, you're giving it along just on the lateral aspect of the abdominal wall. It's mainly indicated for lower abdominal surgery because it blocks this T10 to L1. And you don't need too much volume. And what it does is that basically it blocks the skin, the muscle, the parietal peritoneum that is supplied by these dermatomes. And so how does that happen? It blocks some of the intercostal nerve, subcostal nerve, iliohypogastric, ilioinguinal nerve. And if you've given enough volume, it usually provides a good duration of action. However, if you go too deep, you can actually enter the peritoneal cavity and you can cause bowel injury, which is why this is a tap block is recommended to be done under ultrasound guidance. So how do we do it? You place your probe as shown earlier, and then you look. So you can use this for, say, appendicectomies, colectomies, hernia repair, patients who have spinal abnormalities, so you don't want to give a central neuraxis block. And the landmark is you go at the mid-axillary line, as we've shown earlier. Here is the mid-axillary line. And you find that the lumbar nerves, these rami, they lie in the intermuscular plane between the internal oblique. Here you can see the internal oblique muscle, and this is the this is the transverse abdominis muscle. So if you've injected into here, your drug is going to go into the abdominal cavity, you need to inject into the muscle over here. And the important thing to remember is it provides unilateral anesthesia to the skin, muscle, parietal peritoneum of the anterior abdominal wall. So if you're having surgery that's likely to cross on the other side, you need to give a bilateral block, and which means you need to calculate your total dose so that you don't go beyond the toxic dose. Now, rectus sheath blocks, these are really indicated for surgery around the umbilicus. Fairly small doses required, and it's along this whole midline abdominal, if you're having a midline abdominal incision. But so you have to, I'm not sure if some surgeons don't want any distortion here, then they may not be happy with it. But it's a useful drug. But again, you can very easily, so you inject your needle. Here you're holding the needle and it's progressing, and you just this is the posterior aspect of the rectus sheath, and you're just injecting your drug from there. Femoral nerve blocks, the block that we use very commonly in adults. I don't know how many have been using it in children, but any surgery this is the inguinal crease, any surgery of the anterior thigh, femur, patella, the knee, or if child has had a fracture femur, it's very useful that you can pop that in pre-op. And so it really helps reduce the pain in any trauma in this area, provided the skin is intact. This is the dosage, and it really derives its roots from L2 to L4. And so it's the anterior medial thigh, the knee, the medial part of the leg, and the medial part of the foot. So complications here is that, remember, it lies very close to the artery and you need to be cautious. So if you look at this, you're giving it at the level of the femoral crease, and here you notice that the nerve is hyperechoic. So that means you're seeing it not as dark, but you're seeing it as whitish, and it lies just below the fascia. This is your fascia iliaca, and it lies immediately lateral to the artery. So you have what is the nerve, the artery, the vein, then there's a little bit of space, and there's the lymphatics. So it's really important that you remember that you're so close to the artery that you can very easily inject it there, especially if your needle is moving or has, if you're going in this direction, you can very easily, few millimeters and you're in the artery. You need to be very careful about that. We move then to the fascia iliac block, which is a 3-in-1 block. And basically what you're doing is you're giving a larger volume and you're blocking 3 nerves, the femoral nerve, the lateral femoral cutaneous nerve, the operator nerve. And so this can be used for hip fractures, and accurate placement along the femoral nerve is very important, because the whole idea is that it spreads, the local anesthetic should then spread that's where your needle tip is. It should Give a good volume, it spreads caudally, laterally, medially, and it blocks these nerves. Popliteal sciatic nerve is again for procedure. Here you need to have the child lateral or prone, and you need to identify the popliteal artery, the popliteal vein, and then you move your probe up towards the track the nerve up above the popliteal fossa, and then you will see the common peroneal nerve, tibial nerve, very small, again, slightly hyperechoic bundles that you can see here. And you need to be very cautious again that you don't inject it into the vein or the artery. There has been a case report of an adult patient where popliteal block was given and bupivacaine was injected, and this patient had a seizure and could not be resuscitated. In fact, had to be put on heart-lung machine for several hours. So please remember that one has to be very careful about this, and you need to capture both these nerves. If you go too low, you might miss one of them. Supraclavicular, we now come to upper limb blocks. Supraclavicular block, probably again one of the commonest used block for, especially if you're using ultrasound guided. There are a number of some people who prefer the intraclavicular block using again ultrasound guidance, and it really is an easy block, and it provides good analgesia for the entire arm. And you need to block basically the roots of C5 to T1, and it covers most of the upper extremity but spares the suprascapular nerve. You can put in catheters, so they preferably not, that will probably go in for preferred in ankle V, but you can put in a catheter. And one of the important things that at all times you've got to, here, I don't know if you noticed, but you can see that this bundle of nerves are not hyperechoic. So nerves don't necessarily always look dense, they can actually look dark. So you have to identify the artery, the subclavian artery, and go medial to that. And the important thing is that you're very close to the first rib. You can very easily puncture, go either into the artery or you can go into the pleura. So you need to be aware of that and check, get X-rays done. So basically you place your probe above the clavicle. This is the head, that's the clavicle, and you identify the artery, and you find that the plexus is just superior and posterior to it. And you don't start the block unless you clearly identify the rib and the pleura, and you maintain the pleura in view, because remember, it's a moving structure, because otherwise you can cause pneumothorax. Erector spinae block is, this is performed, as you can see here, it's just lateral to the spine. And that would be an indication if you have a rib fracture, some high thoracic surgery, in which case you'll have to give both sides. And it has a very good safety profile. Basically, you are blocking the ventral and dorsal rami of spinal nerves, and they diffuse back from the site of injection. So if you have here, you have the I'll show you what actually transverse process. You can see the transverse process. You identify that, and then you target the facial plane just deep to the muscle, and you have to orient your probe in the longitudinal direction, and you slowly scan from medial to lateral, and then you see this hypoechoic transverse process here, and that's where you inject. And you should see a good spread of the muscle, and then you inject your drug. These are some of the doses, indications. So TAP block, which you remember you give in the mid-axillary line, just subcostal, for lower abdominal surgery. And most of them, you're giving an average dose of about 0.2 to 0.5 ml per kg per side, if it's a rectus sheath or a TAP block, and for femoral itself. Popliteal is good for foot and ankle surgery, supraclavicular for upper extremity. And these are some of the complications, as I've already mentioned. So there's some controversy of, central versus peripheral blocks. And I think generally the feeling is go as central as necessary, but as peripheral as possible, because obviously the more centrally you go, the more damaging if you do have complications. And this was an interesting study where they looked at complications in France, and they found that central blocks, there's more problems with epidural compared to spinal, compared to caudal, and peripheral blocks far less. So most of the time it occurred, these problems occurred due to at the time of needle placement. So it was either in the nerve sheath, etc. And some of them occurred once the needle is in place. There were visceral punctures. Seizures also have been noted. So big advantage, I think, is that we are all really happy. And I know that now a number of institutions and anesthesia departments have got ultrasound machines, because they really make a huge difference, because you're seeing and you see and you believe, provided your mind knows what you're seeing and your brain has the knowledge. So before you give a block, just go online, check what structures you're looking for, and then you can make a huge breakthrough in providing regional anesthesia. And success rates are much better, less complications, easy to use, and you'll find that if patients and parents are so much happier. And so there are many advantages of, for instance, there are studies where they've compared where you use the classic landmarks compared to ultrasound guided, and found that the ultrasound guided had much higher success rates and less analgesic supplementation. Because remember, most of these blocks are given in children under general anesthesia. So in conclusion, begin to start using regional anesthesia techniques whenever possible. That's the take-home message. But you have to learn the art of ultrasound guided assisted regional anesthesia. We all struggled. Nobody taught us. You got a machine, you looked up the literature, looked what structures you're looking for, and you've got to do this in your spare time. Try out on your friends, try out on babies when you're waiting for the surgeon, etc. You'll get the time. And the important thing is keep within your dose limits of local anesthetic. Though local anesthesia systemic toxicity is rare, it does occur, and when it occurs, it can be disastrous. And so you need to be always on the lookout that you do not create this situation. And therefore, I can't stress that you don't just give a block somewhere without monitoring. You need to monitor your patients. You need to follow up. How many of us actually follow up? Because interestingly, when they've looked at closed claims in cases in the US, they found that, now anesthesia is so safe. You hardly have any respiratory problems, cardiac problems, arrests, now that we don't use the safer drugs. We're using safer drugs. But there are case reports of problems after regional anesthesia. So you need to be very careful and get interested and follow up on your children when you have time. This is a very satisfying process. I remember getting so excited when I used to borrow, ultrasound machines, go down to the radiology department to learn even before we got ours. And then you start trying it out on, and you realize, like, I was doing so many ilioinguinal blocks. And then I realized, you get the pop, but actually your needle's gone through the peritoneum and you don't know it. So I started learning that actually I can recognize it once with the ultrasound probe. And there's nothing more satisfying than a comfortable child and happy parents. Thank you.
Golden word, ma'am. Really. Thank you very much, ma'am, for this exhaustive lecture. It was very nice hearing you through all the safety precautions we have to take, the central neuraxial blocks and the peripheral blocks. One personal question, ma'am. One major pediatric case, what we get, it's so simple, is circumcision, ma'am. How do you manage circumcisions?
I give penile blocks. I haven't, I mean, I couldn't obviously cover all blocks, but
Okay.
I give penile blocks. And at one time, unfortunately, in neonates, actually, I used to try giving, putting EMLA cream beforehand. When you put EMLA cream beforehand, before you actually have, that also helps. And the older child, I avoided giving caudals because, they start running around soon after when they're okay, and then they're not yet stable on their feet. So if you're thinking of, that's where I'm saying you go periphery rather than centrally, and then give them round the clock paracetamol. And I actually came across one case reports, I mean, where a group where they actually apply EMLA cream afterwards, but then there is a concern about methemoglobinemia, especially in neonates. So, if you are trying to use that technique, it also helps smooth the post-operative period, but you've got to monitor saturations and be aware of that.
Yes, ma'am.
So, but that's a very important question because, that is a very, very painful procedure and the boys are so uncomfortable. So you tend to use a combination of IV or rectal paracetamol and some amount of try and avoid opioids, of course. Thank you.
Thank you, ma'am. What additive do you prefer for a caudal, ma'am? Suppose the child has a hydrocele or an inguinal hernia operation done. Most of the time, we won't have the luxury of putting a catheter inside. So we rely on using a additive. So what do you prefer, ma'am?
I think now it's boiled down to clonidine. Most people just use clonidine because there is some, one is always worried about because it is a central block, so other drugs like midazolam and ketamine. So I think the most popular one is clonidine now. And you don't really see the bradycardias that you do, the dose that you use.
Okay, ma'am. Thank you, ma'am. There is one question about the sizes of epidural or nerve block catheters. Is there anything specific for children?
I'm not sure. EKTA, can EKTA help me on that? I'm not 100% sure about catheter size.
Yeah.
Are you aware?
Yeah, ma'am, for less than 10 kgs, usually we use 20 gauge, 5 to 10 kgs with 24 gauge catheter. And then less than 20 kgs, we use 19 gauge. I think the catheter is 22 or 23 size. Yeah. And more than 25 kgs, we use normal 18.
Normal, yeah.
18
and I think generally what they recommend is you don't push the catheter in more than about 3 centimeters or so. That is what is generally recommended, which is why, this whole idea of pushing caudal catheters all the way up, there are concerns. But, in our situation where somebody is not comfortable putting an epidural and they'd rather put it through the caudal, it can be done. But as they say, you have to be very cautious when you pull it out. And also you need to tunnel. You need to tunnel the catheter and bring it out more to the side. And the reason being is that you're more likely to get, the site contaminated and infection, which can spread.
Is postoperative urinary retention a problem when we use caudal or spinal, ma'am? Because in adults we see, sometimes even in pediatrics, the surgeons keep telling this could be because of that.
Yes, it can, but I think, it hasn't been too much of an issue. Hasn't been too much of an issue. I think I've just seen one child where we actually had to put in a small little red rubber catheter to drain, but otherwise I haven't really seen. It's not a big problem that has been reported. What's been great is that if you use a lower concentration, then you have the analgesia and you don't have motor blockade, and these children happy running around. But you have to ensure, especially if it's daycare, that the child is always accompanied by, they're not running and they suddenly lose their muscle tone. So which is why I think people are going more away from caudals and into more peripheral blocks.
Yeah, central when necessary and peripheral whenever possible. That is
Yeah.
yet the golden word, ma'am. We have to follow it.
Yeah, but you know, it's
Okay.
so easy to give a caudal. So, you know, you tend to pop it in. But as time went on, I started, once you get used to doing other blocks, you start moving away from that.
Ma'am, equally having done ultrasounds for adults and ultrasounds for children, do you find that there is any differences in the tissue differentiation, ma'am? Do you have any? Because I do find that sometimes the facial planes are well seen with the children than adults because of the less fat in the subcutaneous tissue. Sometimes, do you have
Yeah.
that?
Yeah, but I think it's again, every case that you do, I mean, now I haven't practiced for some time, but I'm sure Ekta will agree with me that I always confirm what is the anatomy I'm supposed to find. And then I go there, you know. So in fact, so then I can say, okay, and I'm not so sure. And then you go back to checking again. Is this what I'm supposed to see? Am I using the probe wrong? Am I using the wrong kind of technique? So it's so much of living and learning. Which knob to fiddle with. Am I right, Ekta?
Yes, yes, ma'am. I completely agree.
Yeah. Because, you know, sometimes you just pick up the probe and then you don't have the right settings or you, etc. So but I always confirm my anatomy, you know, this is what I should be seeing. And then it just pops out when when it's clear.
That is another golden word, ma'am. Before putting in the needle, confirm your anatomy. So we have got a lot of golden things from you, ma'am, today.
No, you just never stop learning, doctor. You kind of you look and you know, because I mean you're doing so many blocks and so many other things. So it's at that time you're concentrating. What should I see? How should I hold my probe? Which probe should I use? Do I need to change the probe? You know, all those things are there. You don't just pick up the machine, some other probe might be on it. You know, you realize you're using the wrong probe. So there's no easy way out. But it's a very exciting journey, which I embarked on late in my career, and I found it very exciting. And I think now there's so many more blocks that we can use. And that's very useful. I think time is up. I hope I'm glad I kept the time. I wasn't sure. You gave me something I can write a textbook on.
But today we had a very mind exploding session today, ma'am. Both of you very two pillars in this field, giving a very nice lecture. It was all of us, we felt very happy, ma'am.
Thank you so much, and thank you for this very kind invitation. I know that Dr. You took a lot of trouble to locate me. I got a call from the Vellore asking whether he could call me. So thank you for seeking me out, and I hope I was useful to you and postgraduates who are listening. Thank you very much.
Thank you, ma'am. On behalf of Online Anesthesia, we thank EKTA Rai, ma'am, and ELSA VARGHESE, ma'am, for coming to the session and enlightening us with this very good topics. Thank you very much, ma'am.
Thank you. Thank you for the invite. Thank you so much.
Goodbye. Thank you.
Goodbye, ma'am.